and Information Management program here at UCF. Welcome to the School of Global Health Management and Informatics Webinar Wednesday Summer Series. A couple of housekeeping items before we get started. To our attendees, please be sure that you keep your microphones muted and your web cameras off. We will be taking questions from the audience at the end, and we ask that you use the chat function to submit your questions at that time. We will address them to the panelists in the last 10 to 15 minutes for the open Q&A session. Also, please remember that this is a live event and do your due diligence to keep your personal information protected. For any current students in attendance, this is a UCF event, so all student code of conduct rules and regulations apply. Thank you so much. I'm going to hand it off to our host, Katie, and she will get us started.
Thank you so much, Thea. Just for everyone in attendance, Thea Samaki is one of my colleagues here at the school, and she does work with our health informatics and information management students. If you have any technical difficulties or hearing issues, please message her privately for any troubleshooting, and we'll see if we can't get that fixed. Anyways, my name is Katie Terry, and I'm the head of communications for the School of Global Health Management and Informatics, and your host today, and I'm super thrilled to have you all with us. Today's topic is intersectionality in healthcare facilities. So we definitely believe healthcare is more than just doctors and nurses treating patients. It's the culmination of clinicians and administrators working together to treat the whole person. And today we want to take a dive into those collaborative relationships, what they look like, and some of the IT, medical records, those and how that works together with the administrators and clinicians. I'd like to start off by introducing my colleagues on faculty here. First, we have our executive in residence, Shannon Elswick. Shannon is not only has extensive experience in healthcare facilities, but he's also one of our student engagement experts that helps head our mentor pods and guides our students toward lucrative leadership careers in healthcare. Shannon, to get us started on the conversation, where are some areas you see health information management and health IT professionals connecting with clinicians and healthcare facility administrators?
Well, thanks, Katie, and welcome to all who are here. In the days, and I told my fellow panelists earlier, my first job in medical records was in 1984. And we were in the basement. That was at University Hospital in Jacksonville. And we had zero contact with anyone. The director of the department actually met with his colleagues on occasion, but asked for the staff, and there was actually almost no interoperation or intersectionality at that time. Today's modern health information management process in the clinical setting is extremely interactive. And to the extent that physicians are interacting with coders to talk about diagnoses and discharge planners, the information that's generated through the medical record becomes integral to the actual clinical management of the patient. So it's not just information going one way and getting captured and people not having input into the process. It actually now information flows both ways. And then there's some extremely interesting interactions that happen when we go to implement a new EHR and all of the people that need to be involved in those decisions and in the architecture of those systems. So we've come a long way since 1984, and our panelists have some very rich experience in these areas as well.
You know, you touched on the decision making, from your experience or what healthcare leaders are dealing with today. Where in the process do you think health administrators are working with the decision on which EHR system to implement?
There are three places where healthcare administrators engage. One is at the very beginning. One is at the very end when the decision's made, and one is in the middle from the first decision interaction to the last one. So from the very beginning, the executive team is detailing the outcome that we need, but then we're handing off to some very dedicated task force teams that are going to work through a lot of specifics, and then they bring product back to the executive team. We review and send back, and there's a very, very detailed fabric of planning that goes into just before we even put out an RFP to the vendors. And then once the vendors come in the interaction with the people downline is extremely important because they have knowledge that we don't. They can ask questions that we don't know to ask. So we get information, we share the RFPs, the staff, both clinical and on the HIIM side will give us feedback that we then take back and scrub. And then of course the interaction really goes up when you decide to buy something and implement it. It's quite the process these days.
For sure. Thank you for touching on that. We'll definitely get a little bit more details on the downline you were talking about as where you need to get that feedback from some of our panelists today. Thank you, Shannon. We'll discuss more with you in a bit. Our next panelist from within, we have our Health Informatics and Information Management Program Director, Dr. Alice Noblin. She's joined us many times before, so welcome back, Dr. Noblin. You know, we're going to be talking a lot today on intersectionality between health information management and the other key players in healthcare organizations. One big difference between health administrators and the health informatics information management side is the need for some more of that clinical knowledge. Can you break down what clinical knowledge that is and why it's important for an HIM professional to have that deeper understanding?
Sure, thanks, Katie. And again, welcome everybody. So for the undergraduate HIM program, we do require anatomy and physiology as prerequisites. And a lot of that has to do with the medical codes that have to be applied to every patient's medical record when they're discharged, basically, or to their medical case, I guess we could say. We want to make sure we capture a full picture of everything that occurred during that admission for the patient. So we are focused on continuity of care for patients through the collection of clinical records that occurs. And we want to make sure that we capture that through the coded information as well, which actually is good research data for decision-making that Mr. Ellswick was talking about. Like when it comes time to make administrative decisions, having that coded information as far as how many gallbladders were removed or how many other types of procedures that were done as to why we might want the next level of technology for a certain area of our facility. So really a lot of it has to do with the coding piece for the clinical data, but HIM professionals do interact with patients a bit through maybe a patient portal implementation type initiative at a facility. So they are working with patients. We're not explaining things on a clinical level to help them make clinical decisions, but we can at least give them a definition of information that is contained in their record, along with anatomical references that would go along with that. So it is important that HIM can kind of talk to both the clinical piece and also administrative and the patient side as well.
Awesome. Thank you so much, Dr. Noblin. We'll actually tie some of those pieces together. Some of our panelists today have that coding and that information entwined in there. So our last but not least, coming from our internal, is Stephen Tunn. He is not only an instructor here at the school, but he's also the internship director for both our undergraduate and graduate health informatics programs. But he also has extensive experience in health IT. Stephen, you were formerly the assistant director of IT at our College of Medicine Regional Extension Center.
That's right.
And you do a lot of work with electronic medical records or EMR software and the like. Can you give us a quick breakdown of the decision process on that software? Like, what did implementation look like?
Sure. So thanks for having me, Katie. And if I can take maybe a minute to talk a bit more about my background, which includes that role, the panel and perhaps the audience would know how to address questions to me. So I am a computer hobbyist all my life. I love computers. I've always loved computers. And I've really spent my entire professional career in IT. Years ago, before I was in health IT, I was consulting and helping small businesses, lawyers' offices, dentist offices, build databases, get e-commerce set up, run analytics so they can make better decisions so their offices can make more money. And then fast forward and coming here, I actually worked with a local EHR vendor. So I got to see that side of it, the vendor side of it. I forget the actual title of my role, but I did everything technical from build out to project management, implementation to ongoing support. And then shortly thereafter, I joined the College of Medicine's Regional Extension Center as a clinical analyst. And that role really gave me extensive experience with EHRs. So I had consulted for many years prior, but now I was looking at electronic health records and helping local providers identify the best certified EHR solution for their practice and get successful with implementation, and then meaningfully use that solution to receive some of those incentive dollars. And so meaningful use is actually a term that describes the appropriate use of an EHR. Following that role, I was promoted to Assistant Director of IT, where I continued to research and make recommendations regarding EHRs, both to our analysts, but also to our clients. And so to answer your question, what is it like to implement an EHR? This is a tremendous investment. Even the smaller practices will spend tens of thousands of dollars, hundreds of thousands of dollars. Big health systems will have budgets of millions of dollars, even billions of dollars. As you may have heard, the VA is doing a whole change, migration from one system to the next, and it's anticipated to cost about $7 billion. So this is an extensive purchase. What we found back then, and I was doing this about over a decade ago, was that practices were purchasing and signing contracts without even trying the system. And it was insane to me to see that you would invest time and resources and money into a system without trying it out. The challenge is that most providers, well, small practices are physician-owned, or many of them were physician-owned. So physicians aren't necessarily the most tech-savvy people, at least back then, and they didn't know what to pick. We went from a situation of having about 200 certified products, certified meaning that the Office of the National Coordinator has established these certifying bodies, and these products have received the stamp of approval to be used as a certified EHR. We went from having 200 to over 2,000. So you can imagine how complicated it was for these practices to pick the right solution. So without guidance, they probably couldn't do it. So we were involved the entire way. I was a clinical analyst and a senior analyst. Very much as what Mr. Ellswick was mentioning, it is at every step. We want to make sure that we do assessments in the very beginning. We want to make sure that we assess the needs of both the staff, the clinicians, the administrators, the health IT, to get everyone's voice and to get their needs and their wants and to ensure that we can deliver on that product. But more importantly, to demonstrate that we had considered their opinions and their requirements in the final decision. Because when the users know that they have some skin and some investment in the final product, they're more likely to support that. So it was a very interesting experience. We were very successful. We got, I was assigned over 60 practices, and all of my practices successfully adopted products and we're able to meaningfully use those products. So it is an extensive process. We run any number of assessments, facility assessments to gauge where servers would be hosted, where wireless access points would be installed, and it is absolutely a collaborative experience. Ideally, you can get everyone into a conference and get all of their interests and all of their requirements and be able to accommodate. But in the real world, that doesn't happen. In the real world, you get representatives from the respective departments and then come together to make a decision. And I think one of the interesting things that I was able to create was an objective scoring system. We would create RFPs, as Mr. Ellswick would mention, have a short list of 10 products that would deliver the solution that the practice was looking for, go into product demonstrations, ask the vendors to run through a scenario that we had created, because anytime you ask a vendor to demonstrate a product, they're going to demonstrate it perfectly every single time. But the only time that you can really catch them on their product is when you tell them what you want them to do, and that's when you truly see it in action. So we walk these practices and providers and the staff, HIM and support teams, and the health IT departments, looking at these vendors to make an objective decision. So it's a very interesting process, and I'm quite proud of the achievements that we were able to make.
Thank you so much, Stephen. Your overview is the perfect segue to go into introducing our guest panelists today, as they can give us a more in-depth look into what that looks like after it's come from you and into the industries. So it's my absolute pleasure to introduce our guest panelists today. We have Philip Duong, he's a hospital billing partner at Nemours with extensive experience in clinical documentation improvement, revenue cycle, and billing. Additionally, we have Isabel Quintana, systems analyst at Orlando Health with a specialization in electronic health record, or EHR, systems and HIT and compliance. Philip and Isabel, welcome. Thank you so much for being with us today. Isabel, I do know you did mention your camera is not working, but we're super happy to have your voice present with us. So I'm going to go ahead and start with you, Isabel. You have similar experience and involvement to Stephen, as he was talking about, in the IT and electronic medical record systems and the like. And you've been working closely on the new Epic implementation at Orlando Health. Can you tell us a bit about Epic and what that process has been like?
Sure. So I have been with Orlando Health for a little bit over a year now. This project was pretty extensive. It started, I think, about 3 years ago. So I even got involved, when they were about halfway through the process. So when I was getting involved in this project, it was when, we were gearing up to build all of the systems, going through all of the testing, and just getting all of that initial build ready for our initial go live. So with Orlando Health, because it's such a large network and they were going to put everything on the system kind of all at once, it was split up into 4 different go live waves. So we had the first set of hospitals going live in January, the second set of hospitals going live at the end of April, and then we just completed our last 2 go live waves, one in June and then one just at the end of July. So my role within this process, I am a systems analyst on the patient access team. Patient access touches a little bit of everything. So it's been a really interesting experience for me. We are responsible for creating everything a patient needs in order to not only schedule their appointment, but get all of their insurance information into the system, get everything that they need ready to go so that they can actually receive the care that they need. So whether it's in a clinic setting or within the actual hospital itself, that is what my team is responsible for. So we are, we're working with the practice administrators, we're working with the corporate directors, we're working with physicians, just to make sure that we're getting everything ready for what they'll need in order to give that patient all of the care that they're that they're going to be needing. So it's been a really interesting project for me. It's my first time really being this heavily involved in implementation from this perspective. In my previous role, I was more of an end user. So I got to experience what the implementation was like on the other side, what it was like kind of learning everything and learning how to use everything, and building it and seeing it from this side has really been a huge learning experience for me. So it's been really great for me. As far as this project goes, it's definitely, I think, one of the bigger projects that I will probably ever be involved in, just because of how big Orlando Health is. But having the background that I do and, the education I received at UCF actually has been really, really helpful for me. My background is, I sort of have a background in a few different things. So between compliance, IT background, health information management, I've sort of been able to pull all of those together to really help me out in the role that I have now. So for the specific systems that I work on, I'm working with, patient work queues. I'm working with reporting dashboards. I'm working with the different interfaces that are required to, making sure that there's interoperability between a few different systems. So even though Orlando Health, everything's on Epic, there's still a few outside systems that Orlando Health is using and engaging in for specific areas, for specific specialties. So having a background with interfaces has been super beneficial for me to help me, set our system up for success when it comes to interoperability. I don't know if there's any like more specific questions that you have about anything with the
Yeah,
project. It's
so
such a huge project. It's hard to kind of narrow it down.
No, definitely get it. So, just getting that overview is good. We're going to dive down into a couple of things you've already talked about, like end users and the patient access and interoperability. But just the overview, it's good to know because Epic is a huge system. It is epic. And Orlando Health is a huge system and it's a big undertaking. I want to jump right over to Philip. You work on the billing and the CDI side, how do the implementation of these types of EHR systems impact revenue cycle and billing?
Yeah, thank you, Katie. It's such a pleasure being here. EHR is really important from a billing perspective because we have to review each documentation to make sure that the procedure performed on the patient and the diagnosis given to us meet medical necessity. If it fail medical necessity, then we will get a denial from the payer and the hospital will lose out on like reimbursement from the payer, and they had to eat up the cost for the procedure. So it's really important to have a good EHR system and to make sure that everything is documented correctly, accurate, compliantly, and safely in accordance to the state and federal law.
For sure. So where you're at, is there, because I do know, we're going to touch on interoperability here in a second, and some hospital systems have one system that connects to each other, but does the billing systems and the medical record systems, are they the same or do you have two different?
Okay, so at Nemours Children's Hospital, we use Epic, and for Epic, everything is connected into one system. Whereas when I was working at Jupiter Medical Center, we use Cerner, so we have to have like multiple like application system. And for me, it's kind of confusing because you have to open one thing and then you have to close another thing. Whereas Epic, everything is right there in one system. So it's very convenient for me. And I actually like the interface for Epic. It's really user friendly. Whereas the other system I used in the past, it feel like you're going back in time in the 1980s, where it's like a DOS, where you have to like understand the, I don't know, HTML code or something like that.
Lots of ones and zeros on the screen,
Yes,
trying to figure out what that means. I gotcha. Well, that's great, to hear that our two big systems have already implemented Epic, so that's got that streamline. Stephen, I'm going to bring you into this because there are systems who, like Philip mentioned, have the two different talking to each other, and it's really important for interoperability. Can you give us a little background on interoperability and how that works for those not using a system like Epic?
Yes, absolutely. This is the ongoing challenge that we have today. We've achieved a high level of interoperability. This is partly because of the consolidation we've seen over this last decade. As we see fewer and fewer products on the market, as we consolidate down to our Epics and our Cerners, there are fewer vendors out there. So we have fewer solutions and platforms to connect with. The challenge with interoperability is it's multi-leveled. One, how do you send information securely from one organization across those organizational boundaries into another system across platform differences? And so it's not really a technical challenge. It is more a people challenge. It is a standards challenge. It is a collaborative challenge. If we could have a national standard, a standard by which we all operate, then interoperability would be achievable. And when I say interoperability, we're talking about the effective exchange and understanding what that means. That second level is semantic. So even though you are able to send the message and it's received, for example, email, any one of us can have a Gmail account or a Knight's Mail account, an AOL account, some still have AOL, and the message can still be sent. So there's absolute interoperability with Gmail. But if I were to send the message in, say, Chinese, only a few people would be able to understand it. So the meaning can get lost. None of these systems speak the same language. None of these systems use the same data dictionaries to codify what they have in their system. So even though they send it, the other systems aren't going to understand it. So we really have to come down with some national standards or even some global standards. And it's not a technology problem. It's a people problem. We have to get people who can make decisions come together, establish a norm, and then make that the requirement. And we would achieve interoperability. I say this all the time. If there was a catastrophic event, if aliens were to come down and say, we are going to ray gun Earth, right? And you have 6 months to achieve global interoperability for all healthcare, we could do it. We could absolutely do it. The technology is already there. It's just we don't have agreement. So that's really the challenge today. And this is a huge point. If you go to any of the large conferences, you'll see entire pavilions and expos just on interoperability, trying to get us to be able to exchange information. The world's getting smaller. We have medical tourism. You want to know that if you go and travel somewhere else, that your records can go with you, and that it's semantically interoperable, and that no matter what language it's written in, the other providers and health systems would be able to treat you. We're getting better. We're getting close, but we're not quite there yet.
I really like how you relate it to, it's not a technology problem, it's a people problem, right? Because this leads to my curiosity. Isabel and Philip, you both deal heavily with, the clinical documentation, these EHR systems, but I'm super curious as to where clinicians come into this process. We did touch on it earlier. I think both Shannon and Isabel mentioned about getting them trained. What challenges have you seen or heard of when it comes to translating or getting that interoperability with these systems and the upkeep from the clinicians? I'll start with Philip, you first.
That's a very excellent question. Would it be okay if Isabel start first?
Yeah, sure. Isabel, you go ahead.
Yeah, I mean, I think the biggest issue that I've seen in my experience is just making sure, kind of going along with what Mr. Tan was saying with interoperability is data, right? So it's all data. You need quality data. So one of the struggles that I have seen is just making sure that the appropriate documentation is there. So like when we're sending that information out, just making sure you have all of the pieces of the puzzle to get that patient what they need. So for example, if there's a CPT code missing or something like that, that's going to affect the patient's care. That's going to delay the patient's care. So, I've seen instances where just because, a CPT code wasn't sent with a referral or something like that, then, you spend a few extra days, one office is trying to call the other office, trying to get the CPT code. And it's such a simple thing to do, right? It's just that code and you have to make sure it's on the form. But if it doesn't get to where it needs to go, then it can cause, like a couple of weeks of delay, or, the patient doesn't get the appropriate authorization for whatever procedure they're getting. So the biggest issue for me is, from a clinician standpoint with the training and everything, is just making sure that they feel comfortable putting in all of the pieces they need in the EHR. I remember one of the things that we've always talked about, even going back to the classes at UCF, is this resistance to training. You're switching over to an EHR. It can be really overwhelming for everyone, not just clinicians, and just learning where all of the pieces go, right? So you have this great system that you've just spent tons of money on. It's can do all of these great, amazing things, but if you're not comfortable with it, and if you're not sure where to put the appropriate information, then you're going to see a breakdown in how that data gets captured and how that data gets translated into another system.
For sure. So Philip, going back to you, I guess I'll break it down this way. When it comes to the billing and revenue cycle, is there a lot of translation that needs to happen from what the physicians input to when it gets to, okay, now we need to do the medical coding and billing?
Yes. So basically, in my department, we have coders and CDI. So the coder would actually review like the procedure and the diagnosis to make sure that it meet medical necessity. So let me explain it and give you like an example. So basically, if a procedure like an X-ray was performed on a patient, and then the physician put like I don't know, vomiting as the diagnosis, that clearly would not meet medical necessity. So we would query the physician and ask for further diagnosis, or maybe we can ask them to elaborate more on what the diagnosis is in order to medical necessity. The payer will review it to see if further physician department not reasonable denial for it. Okay, here.
Philip, it sounds like you're cutting out a little bit. I'm going to go ahead and go on to another question and see if you can't get reestablished with us really quickly. Say if you could message Philip and we'll bring him back. Shannon, I want to kind of go to you really quickly. From the administrator perspective, we're talking about how can we make these intersections better, and what would it be in an administrator's role to help this training to go back and forth between the clinicians, the HIT department, and the administrators?
So just a couple of quick things. Just from a history perspective, as we implemented our early EHRs, all of our clinical professionals demanded, and we felt like they deserved the best of the best clinical packages. So the cardiology package, the ultrasound package, radiology package, the orthopedic package. And that was the genesis of what I call the patchwork quilt of electronic health records. We had one core and then everything else was hung on it. And just like Philip said, there was a large financial piece. It was over here clunking around. Our first conversation as a group of senior executives, as I remember, was in 2005 about how do we eliminate the patchwork quilt and get to a more common solution. And so Epic was talked about over a decade before the decision was made to actually make that transition. The other thing that I would want to mention is when you think about training, many people don't even think about the balance sheet aspect of purchasing and training an EHR solution. And just for the finance gurus out there, when you purchase an electronic record, you can capitalize that purchase over a period of time. The problem is the average life now of an electronic record system is getting shorter and shorter and shorter. So your capitalized period is shorter, which means that your ongoing expense is more. The interesting part though, Katie, is that it would be cost prohibitive, except for the fact that we can capitalize the training. And people say, oh, that's great. You don't have to expense all that extra training. The problem is you're training the people that take care of patients. So you're taking people out of the workplace into a dedicated training scenario, and training is extensive. So we're pulling them out of the workforce and we're replacing them with people who are also in the workforce. So often paying overtime, and where do you charge all of that? But the other thing about training, I think that really enhances your chances of success, and we found this over multiple implementations, is the last thing you want is to purchase a record and have a bunch of people fly in from Philadelphia or New York who are the experts who are going to run around and help people learn how to use the system. So we always pull some of our best and brightest out of the workforce and send them offsite for advanced training and make them our super users. We don't pick those people who are the most technically savvy or not even necessarily the most clinically competent. We're picking people who have good people skills and who can learn and can encourage their peers so that it becomes peer-to-peer mentoring. And it's so much easier for faculty and staff to manage those things. And when I say faculty, I think more along the lines of physicians. The last thing you want is a consultant trying to teach a physician how to do something. You want another physician that person knows and trusts. But the evolution of all this has been, again, I kid about starting in 1984, but this train has been rolling down the tracks. And as Stephen mentioned earlier, it goes faster and faster and faster, and it's harder and harder to keep up.
Absolutely. I like your example. It would be about like me trying to tell you how to do your job. But I definitely see that in intersectionality. I want to go ahead, welcome back, Philip. I want to get back to you. I think we dropped off when you were talking about the example.
Hey, Kate, I apologize for earlier. Can you still hear me?
Yes.
Okay, awesome. I don't know what happened, but the example I was given for medical necessity, if a patient came in for X-ray and the physician put in the diagnosis as vomiting, that would not meet medical necessity. So the coder would query the physician and ask for more diagnosis or a better explanation of what is performed. And once we have like a better diagnosis, we could submit like a claim and release it to the payer so they could review it. And then the hospital would be reimbursed for it. So I feel like it's really important for the coders to have like a good relationship with the physician, because it make it easier for the physician, one, to listen to them, and two, for the coder to ask for the coder to do what is asked of the physician. So it's very important to have those connection and relationship when it comes to those two people.
I'm super glad that you said that, because oftentimes the thought is that there isn't this intersectionality between the two. You know, if you're working behind a computer, you're not talking to the clinicians, you're not talking to the administrators, but really that relationship is integral to be able
Right.
to get to the end user, which is the patient. So thank you so much for that. Stephen, I want to drop back to you. Both, all three of them have mentioned things that, you know, have to do with the IT side of things, and you've built a few software processes and systems. So, you know, when you know, Shannon's talking about the decision-making process, and so is Isabel. What does it look like? Are they giving you a wish list item, or are you looking at who the end user is first?
Yeah, no, absolutely. So you have to identify all the stakeholders. And so end users being one of the stakeholders. But asking for the wish list is critically important, because you want to convey that this is an opportunity for us to improve their current situation. If you hate what you're doing right now, and we can get you your wish list of items, you're going to be more likely to adopt this new system. There's going to be a learning curve, absolutely. But if we can get that buy-in, that investment, that skin in the game early on, there's going to be a much higher chance of success post implementation. Now, you mentioned that I've built some systems. This is true. I also am my wife's an eye doctor, an optometrist, and so we have two practices, and I am 100% responsible for all the technology. So in a lot of ways, I have to put my money where my mouth is, because if I make a recommendation and I deploy technology, make an investment in technology, and by the way, I wrote the EHR. I've written it 3 times now over the last 12 years, each time getting better as I get. My programming skills aren't the best. I'm kind of a hack. I'm a self-taught kind of a computer do-it-all. But this is a fantastic product, I think, and we have it across 2 locations. There's 5 doctors on it, 6 staff, and getting better every day. We have to engage them early. We have to ask the wish list. I get to kind of wear part of the business owner's hat when I do this, because I have to keep in mind that I'm balancing on one desire. I want to make every fancy technology piece available. I want to capture every bit of data point available, but I don't want to slow down the workflow, because that'll slow down the amount of patients we can see, which will then reduce our revenue. So there's all this balancing that we have to do. But to go back to your original question, what is it like to create a solution, or was it how do you?
I was just talking about, you know, where does it start as far as when you start to build it? You know, you talk about all the stakeholders, but does the wish list item come first, or does the operational side? You know, Shannon's talking about the training and all of that. So not only do you have to think about the end user, but you also have to think about those who will be using it for the end user. Yeah. So which decision would you say takes precedence?
So training, absolutely, but that's at the very end, right? So training, and statistics show that we do not get enough training. There's not enough budget for the training. We do not spend enough time on the training. And I don't mean to put anyone down, but physicians tend to underestimate the amount of time they need to learn a new system. That's just how it has been. And I've worked with a lot of physicians. The first step really is to figure out their pain points. You know, what's wrong with your current system? Why do you hate it? Where do you spend your most time? Figure out what are the opportunities for improvement. And then that leads to natural conversations about, you know, what are the things that you would like to have? What are the data points that you're missing? What does your current workflow look like? And the larger the organization, a good workflow analysis will probably reveal many opportunities to fix workflow issues, even without changing out a system. But if you can do a workflow before changing out a system, you can then do a gap analysis to figure out where they're currently at with their somewhat inefficient workflow and what they need to do to get to the better workflow on this new system. So it really kind of starts with a conversation. And that perhaps is the hardest part. I think Mr. Ellswick will agree. Often it's not the technology, it's often not even budget. It's getting the right people, the decision makers, to come together, get their schedules to come together, to sit down and to make decisions. And those decisions that are in the direction of progress, this takes the most amount of time. And then once we've made those decisions, implementations can complete relatively quickly, a year and a half sometimes for a large health system. But again, start the conversation, getting the right people to sit down and have the conversation.
And Katie, there's a really great parallel, and that is when we build a new hospital or a new clinic or whatever, we start with knowing you have to have certain types of rooms and certain number of rooms, and then you go and get the users involved to say, is this the right size room? What kind of equipment do you need? And then you go do more work and you bring it back and say, here's what we have. What do you think? But there's still a point where even in building a patient room, we have the construction people go off and build an actual room all the way, retrofit all the way. And then we send the providers in and say, go look at the room. Now tell me what's wrong. And they'll say, move this light switch over here, move this electrical panel over here. And so we take the model that we built, that we let them see and walk around in, and that's the final tweak. We do the exact same thing with electronic records. After we've done all of that planning, then we send key people to a hospital where they're running this system, and they get to watch and see how it works and talk to the users there. I mean, again, the engagement, the farther you go in the process, the more the engagement has to be and the more intensive the engagement gets. And then Stephen's right. We never have enough time and budget for all the training that we want, which is why users have to be left behind. The consultants can't just leave. We have to have our own super users who are our own clinical experts, and they stay behind.
You know, I really like how, Stephen, you mentioned pain points, right? And the way that you guys are talking about it, it's almost as if those that are, you know, building and implementing these EHR systems, you're your own physicians. You are the physicians, but you're the physician for the organization. And it's almost that like parallel where the physicians are diagnosing the patient, you guys are diagnosing the organization and the pain points. So I like that you called it a pain point because it equates you to that level. And what Shannon mentioned, you know, I'm going to pop over to you, Isabel, because you're essentially the expert or one of the experts working with the Epic system and the implementation. You know, speaking to what he just mentioned, are you finding as you're in the final stages of the implementation that training and overcoming and highlighting those pain points has become a larger part of what you're doing?
100%, I would say. So definitely, I think I agree, you know, 100% with the training as well. There's never enough training. And also, like, what I found is, you know, you go through this training and it's very generalized and it's not specific to what your role might require. So there's always going to be things that you need to learn that are going to be very specific for whatever your specific role is within the organization. So, you know, you might have like a good general training session where you get like a nice overview of something, but like once you get down into the nitty gritty, that's where you start seeing these holes. So one thing which my role is essentially divided into, I would say, two parts. The first is, you know, the build component where we're actually building the system, but then once the system's in place and we've gone live, then it switches to that support role. So I, you know, part of a huge chunk of my day is kind of going through and speaking with end users and walking them through a lot of the workflows that, you know, they may not know, or they may not know that the system can work in this way versus that way. So I spend a good part of my day just talking with them and, you know, identifying those pain points that they're experiencing, and then working through, okay, so this is what the issues that you're running into now, like how can we fix this? So one thing that we've been doing now that the go live waves are behind us is we're moving into our optimization period. So we do have these like post go live meetings where we meet with the corporate directors, we meet with clinicians, we meet with end users, people from, every part of the organization. And we actually go through and we identify, we ask them like, what would you consider the successes and what would you consider some pain points that we need to work through. So that's the phase that we're in now, is we have this system. It's in place, it's there, it's working, but how can we make it better? How can we optimize it? How can we get it to a place where it's working like exactly how you need it to work for your uses versus, how this person over here needs it for what they're using it for. So it's been really interesting. It's almost like we're going back and we're revisiting those initial conversations, because, when you're talking about what you want the EHR to do and what your hopes and wishes are for this system, until you know what the system's like and until you have some experience working in it, you really can't identify what your needs are. So just like how Mr. Elzick was saying with, setting up the room and then sending the physicians in, like that's exactly how the EHR is. So your end user is like, you have some experience in it now, you've worked in it, you're more familiar with it, you're feeling more comfortable. Now is when you can go in and say, okay, like this is what it's doing for me now. Can we make it do this now too? So it's almost like, I don't want to say it's like starting over, but it kind of is like starting over now, because now people know what the system can do and what the expectations are. And now we're just making sure everything's in place and everything is optimized. So.
That's cool. So do you think, and this is just a general question, when it comes to it, both Isabel and Stephen, when you're putting up the wish list of items, do you start with a whole bunch of things and then when you get into the optimization, you take away? Or do you start with just the needs that are presented and then add an optimization? Isabel, you go ahead first.
So for Orlando Health, I think just because it was such a large project and there were so many moving pieces to it, we went with what's called foundation system. So it was kind of like a more of like an in the box version of Epic. So just getting the system in place, getting like the basics in place. We had a few what we call enhancements for specific specialties. So kind of like, okay, like what are like the top items that you need to be able to use this system and get what you need out of it. And then we have what we call the enhancements, which are things that we're starting to move into now that we're in optimization. So what's like your absolute, like if you have to have like your dream wish list, what is it? So now is where we're sort of going through, people are putting their requests in, and we, as an analyst, we go through, we set up time, we meet with them, go through what it is that they're hoping to accomplish. And then it's our job as the analyst to be like, okay, can the system do this? How can we do this? What are the, the potential like work efforts that are going to go into this? Is it going to affect any workflows? Like, how is this going to look downstream? Like just kind of going through and identifying everything that's going to go into implementing this enhancement. And then, we make the decision, okay, yes, we can move forward with it, or, no, we can't. And that's something that, like people from operations have to sort of weigh in on certain things. So, because we're also trying to have like a certain level of standardization as well. It's a lot goes into these enhancement requests that come in. So there's a lot of things you have to weigh when you're discussing like these wish lists.
Right. Stephen, from the smaller scale on your side, would you say it's, just all of it at the beginning and take away during optimization, or reversed?
Well, they're never going to get everything they want. That's just how it is. But we don't want to exclude anyone's requirements or wish list. Make it as extensive as you want it. That's step one. Step two is to look at a phased approach. In phase one, when this goes live in say 6 months, what do you absolutely have to have in your unit, in your department, to do your job effectively? And so have them prioritize the functionality and the features and the fields that they absolutely have to have. And then we can talk about phase two and phase three, and ongoing fine tuning is always going to happen. But we want to make sure that we give them the opportunity to express every single thing they want, so we can express that to the vendors so that they can show us that their solutions either have that today or it's on a roadmap to be able to provide those solutions in the future. So yeah, we take a phased approach. Give us everything you want, prioritize when you need to have it, and we continue implementing as we go when it becomes available.
That's awesome. Thank you so much. We'll go ahead and we'll move into our open Q&A. For our attendees, if you have a question for our panelists, please put it in the chat function and I'll go ahead and read it out to them. While they're writing their questions, I'll ask Isabel and Philip, for rewinding here, because, a lot of the people that watch this are current students or looking to get into the career industry or move upward. What would you say is your one sentence motto for someone who's going to try and get into your role? We'll start with you, Philip.
That's actually an excellent question. I would say my one motto is to be persistent and don't give up. Being persistent means trying to put your name out there, trying to network and connect with other healthcare professionals. And don't give up, meaning that your first 2 years is going to be difficult. But once you have the experience and you have the skill set, then you're very golden. And it will open up many opportunities and doors for you. So don't give up.
Thank you, Philip. What about you, Isabel? That one sentence motto.
Be open to any opportunities. So I know for me, I took a little bit of a winding path to get to where I'm at, and I took some jobs that definitely weren't my dream job, but it's what I needed to do to get the experience I needed. And I feel like because I was sort of open to all of those different opportunities that came my way, I ended up in a place where I'm very happy and I feel very fulfilled in where I'm at right now. So just be open to any opportunities that come your way.
Absolutely. Thank you so much. Dr. Noblin, I kind of want to take it back to you for a second. Both Isabel and Philip are alumni from our program, obviously so successful and super great that we have to have them back. Can you speak a little bit about both of their certifications in RHIA and CCA and how that works with the EHR systems? Like medical records and things like that, getting these certifications and being able to understand how it implements into the HIM field?
Well, within our program, we provide our students the opportunity to get that CCA credential that both Philip and Isabel have, which is Certified Coding Associate. And it's an entry-level medical coding credential. So I would say for Philip, it might have been a help for him to get into his career path, for sure. And then the RHIA is the credential that our students take when they finish our program. And that just kind of tells employers that they have a basic skill set in a lot of HIM areas, that they are well-rounded. They know what a legal health record is, which is a big piece of all the conversation we've had today. Buying all these pieces, we still have to make sure that we can represent the patient's care within a legal document, basically, and that's what we have to do from HIM. So they're familiar with that. They're familiar with the billing and the coding side, the management side, which may be a little more generalized. But anyway, so the credentials are not specific to electronic health records, but all the contents of the electronic health records are represented by the credential information, what they learn to be able to earn the credential. So it's all interrelated, but it's not a direct, a direct fit. So
yeah, and the interrelation is really what it's all about. We can see the administrators, clinicians, and the health IT. I mean, every step of the process involves all of the different departments. We do have a question. I am a new medical records manager, and where I am currently in Turks and Caicos, there's no EHR. Stephen mentioned assessing people's needs first, but are there any other tips and points for implementing an EHR?
Well, I'll put back my clinical analyst hat. One of the other things would be budget. Budget really would quickly eliminate, any number of EHRs. I don't know if Epic would be a solution for you if it's a very small operation. Figure out what your budget would be, your time frame, the level of technical resources you have available. Sometimes smaller practices don't have any technical resources. And if that's the case, you may want to pick a solution that's cloud-based instead of something that's client server on site, so that you have very little maintenance and ongoing support that you yourself have to run. There's a lot to consider. Any other tips? Let's see.
So they also
I would love to know more about your situation, the number of providers, the demographic of patients that you're seeing, the resources you have available, if you have broadband internet, if you have cellular. All of these things factor into which types of systems you can deploy and deploy successfully. And I'll give you some examples. I've been successful working with practices that have deployed open source and completely free EHRs, and I've been able to use those EHRs for meaningful use and satisfy the ONC's EHR incentive program and get the incentive dollars. So it really comes down to some of your immediate goals and kind of your current situation.
So their follow-up to that question was also, you had mentioned, you're self-taught in coding. They asked, should I become certified in coding to help me in my job?
Yeah. So when I mentioned coding, I was referring to computer programming and coding. This person is in HIM?
Yes, they're
absolutely. So
in medical records management.
Absolutely. I think it adds a lot of credibility to your role. It'll help your organization recognize your qualifications. So I absolutely, and in fact, I almost always recommend getting the credentials if you want to be serious within, billing and coding in HIM, to get your CCA. And I think Dr. Knob can certainly speak to any number of other coding specific credentials. I know for our program, the Bachelor's Health Informatics and Information Management program goes hand in hand with the RHIA. And I think that all students need to get that as well.
Working in that industry, yeah, for sure. Well, I just wanted to say thank you guys so much for the conversation today. Super interesting, and just being able to find out exactly how these different things work, especially on the informatics and the IT side of things. We'll go ahead and wrap up today's session. Again, thank you to our guest panelists, Philip and Isabel. You guys are excellent, and we can't wait to have you back in other ones. I'm really hoping next time I can bring in a physician as well, so they can kind of defend themselves against a lot of our fact of, hey, you may have spent many years learning about the human body, but there is this computer that you've got to use as well. But we do have physicians here that I can't wait to bring into the conversation later. Just as a reminder, we do have one more coming up next week on professionalism. So we'll be speaking with Stephen again, and we'll be talking about how to get into these industries and putting your best foot forward and taking some of the advice that Philip and Isabel gave us today. Thank you again. Please, by all means, reach out to us if you have questions. And everyone have a wonderful day. I'll see you next time.
Thanks so much. Have a good evening.
Thank you.
Bye, all.
Bye.